go ahead and open up the meeting, and you can start when you're ready.
Thanks so much, Katie. Good afternoon, everyone. Welcome to the March meeting of the Community Engagement and Communications Committee of the Universal Health Plan Governance Board of the state of Oregon. Say that 6 times fast. Really glad to see you all. Thanks for taking time on this first week of spring. I hope that the weather is treating you okay on our day of spring storms. So again, as I said before, if you need to go off camera due to bandwidth issues, no worries, we understand, but it's great to see your faces. Really looking forward to our agenda today. So as always, we'll start with a quick tech check and roll call, and then I'll review the agenda with y'all.
Thank you, Co-Chair Glass. As far as a tech check goes, we're all pretty familiar with it at this point. I do just want to call out that today we do not have Spanish interpretation, so there's no need to choose a specific language, English or Spanish, which will just all be in English. So apologies about that. And then I will just run right into roll call. So we will start with Co-Chair Amy Fellows.
Here.
Co-Chair Michelle Glass.
Present.
Colin Stackhouse.
Present.
Craig Newton.
Here.
Grace Hokog.
Present.
Jay Brown. Jensina Hawkins.
Present.
John Buzzard.
Present.
Jocelyn Ogden.
Present.
Juan Pablo.
Present.
Mickey Durding.
Present.
Max Brown. I know Max is there, maybe just connecting audio. And Yesenia Hernandez.
Present.
Great, thank you so much. And Max, if you have any issues with audio or anything, feel free to email me, but I do see you're here. So with that, I will turn it back over to the co-chairs.
Thanks so much, Katie. So today on our agenda, we're going to hear from a highly skilled panel with lots of great experience and perspective on grassroots engagement in Oregon and California. And I'm really excited for this conversation to continue to build on our the work we've been doing as a committee to learn from the work that has gone before us and skill up for the work that is ahead of us starting in May to design questions for our own engagement once the draft plan design and finance and revenue design are ready to take out for public engagement to those targeted groups. So like you all know, we're here today because of the work of many, many grassroots volunteers, some of them on this committee. And so I'm excited to hear some reflections on folks who have been studying, doing, and thinking about this work for quite a while. Then we're going to do a follow-up on our strategic communication conversation from last month that we had with Patty Wentz. We're going to have time for committee member updates. Again, this is a time for you all to share the work that you've been doing, engaging with folks, and then we're going to have public comment. And I do hear that we have 2 folks signed up to give verbal comment today. So that is our agenda. And with that, unless there are any questions about the agenda, I'm not hearing or seeing any hands or questions, then we will jump right into the grassroots engagement perspective. And I'm so honored and excited to have Rebecca and Michael with us today. I will allow them to introduce themselves because I don't think I could do their backgrounds justice, but Amy and I had a chance to meet with them in preparation for today, and I'm really excited for this conversation and to get to have it with all of you. So I will turn it over to you, Rebecca and Michael. Thank you so much for making time to join us today.
Great. I guess I unmuted first, so I'll go first. My name is Rebecca Schoon. I know a couple of people on this committee. Colin Stackhouse and I work together on a weekly basis. So hopefully much of the HCO knowledge is making its way onto this subcommittee via Colin already. But yes, I'm chair of the communications committee for Healthcare for All Oregon. I'm sure many of you know it's a nonprofit that's been working on achieving universal health care in Oregon for over 20 years. And we are talking about basically what you all are working on a regular basis. How are we communicating our message strategically? How are we effectively engaging with potential concerns or uncertainty or misinformation that's out in the public? So I'll look forward to sharing what we're talking about from HCAO's perspective. And as a side note, my background, I'm a professor of public health, and my doctoral research was actually how to effectively engage the public in policy-making decisions within universal healthcare systems. So that is an area that is a little further on, like once a universal healthcare system is up and running, how is community perspective, community voice built into its very foundation in an ongoing way? So that's something I'd be very interested in working on this committee with in the future as you get to that point. But for now, I'm interested in hearing what you're already working on and sharing what might be valuable from our perspective.
All right, thank you, Michelle, and thank you all for having me here. My name is Michael Leidy. I'm the president of Healthy California Now, which is a statewide single payer advocacy coalition in California. We have about 60 organizations representing 4 million Californians. And I have been organizing and advocating for Medicare for all type reform since 1990. I'm not going to add up the years because my hairline speaks for itself. But I worked for the California Nurses Association, National Nurses United, for 25 years, primarily as the director of public policy. And I originally really got engaged in healthcare advocacy around the time of the AIDS HIV epidemic because I experienced and saw many friends pass away from AIDS as the government did nothing. And it really showed the importance of patients engaging and advocating for a healthcare system that actually meets their needs. And so from that lesson has really motivated me to do this work over the last few decades. And I have done speaking. I was the Bernie Sanders healthcare constituency director in 2020. So I've done campaign work on this issue as well as advocating for federal and state legislation.
Wonderful. Thank you both. And I just want to share with the committee that I think barely scratches the surface of some of the broad experience and expertise that our two speakers bring today. So we did give them a couple of questions that we hoped that they could respond to. So we're going to open it back up to Rebecca and then Michael again to share a little bit on kind of what their learnings are from the engagement they've done recently, what they might suggest that we keep in mind as we embark on our own engagement, and also their reflections on the distinction between government, like all of us, we're on a government committee, we're part of the Oregon Executive Branch, which is a fairly unique opportunity that we have, but it's a different role than an advocacy role, right? So what do they see as the potential for our role, and what do they see as really the role of advocates in Oregon and how those roles might collaborate together to serve the needs of Oregonians as this work moves forward. So we're going to let them share whatever they want to share from the work that they've been doing, and then we will have time to open it up for questions for all of you. So if you have questions as they're speaking, jot it down and we'll open it up for questions here in a little bit. So Rebecca, I don't know if you feel comfortable going first again.
Sure. Well, first of all, I'll say that the bad news is we don't have a magic answer to give your subcommittee. HCAO is also kind of grappling with some of the same things that you are, like the use of certain terms that are kind of less understood by the public and have more of an emotional reaction versus other terms. So for example, we tend to use the phrase publicly funded universal health care when we are describing what we are advocating for. That's a term that has polled very well. There was a survey by the Oregon, I think, Values and Belief Center, as well as a 2019 study that Warren George, who's a big single payer advocate in our state, he commissioned. And both of those surveys found that 59% of Oregonians, bipartisan, supported this health policy reform when it's referred to like, publicly funded universal health care. And I'll note that in those surveys, they did note that this meant like eliminating private health insurance. So I think that, what you should feel bolstered by is that there is a demand and an interest for what we're working for. And we shouldn't be hesitant to kind of explain and express what this is that we're really trying to achieve. Once people understand that, we find that the problems of the current system are felt by everyone. No one is shielded from it. So once you get past any maybe initial reservations or worries or concerns, the conversation really opens up. But again, we are navigating some of those, some of the issues that I think the governance board is also looking at in terms of, there is a difference in how political parties are framing or coming to the issue initially. We've had really great luck. We have a chapter out in Union County, and our advocates there meet with their legislators who are Republican on a regular basis. They've been building that relationship over years, and we got their support. They were on the healthcare committee, and when we were passing Senate Bill 1089, we had bipartisan support on that committee. So we really believe that it's these conversations, it's building trust, it's answering people's questions honestly and clearly that brings people to the table. I guess I would say, to the question, we can expand more on this, of course, but distinctions between what HCAO does versus the governance board, I would say, since we are an advocacy organization, we have in the past, most of the people that we've been working with or communicating with have been somewhat friendly to the issue. They're coming to us, they're discovering us because they're seeking, some organization who's been working on this. But as we are shifting more towards, expecting either a ballot measure, or at least trying to rally a grassroots movement to contact legislators in 2026, 2027, we are really shifting to thinking about, well, how do we reach and speak to and engage people who might not be coming to us, who might not be seeking us out because they're already a supporter. And my last point I'll say on that is that we do some of that because we are out in the communities. We are out at farmers markets. We are out at community events. And so we are engaging with people who are curious and have questions and have concerns. What I would say is that we know what the people who are concerned about are usually coming with. The Warren George funded survey I mentioned from 2019, there's a whole kind of graph, we're happy to share these results with you too, that mention, taxes, the system will be too expensive, we don't trust government to run it, and we don't want to pay for people who are making bad healthcare decisions. So those are the four main things that people are worried about. And I think the good news is that two of them have really easy answers. The system is cheaper than our current system. And we can go into the specifics of that messaging later on, but that's the thing I think that the governance board should be thinking about, that we know what people with concerns are coming with. How do we listen, honor those concerns, and engage in those conversations in ways that people can walk away feeling, oh, I know more about this issue now, and I trust that my concerns have at least been kind of heard and mitigated. With that, I will stop and let Michael pitch in, and we can keep talking about those themes.
All right, thanks. I mean, Rebecca, you really laid out, the key thematics that we also encounter when people talk about healthcare. And what's striking to me is that this is pretty consistent in the states that I've worked in. Texas, Iowa, Minnesota, New York, Massachusetts, California, Illinois. These issues don't vary that much. I think what we are in is a different period than others I've seen. And, sometimes healthcare is on the national agenda, like during the Clinton plan era. That's when I really started organizing nationally. And so the question was, hey, something's going to happen. What are we going to do? Right. And that's where you put single payer in play, Medicare for all. Other times, like after the Affordable Care Act, there wasn't an interest in systemic reform. Hey, we've done that. And I think we're now emerging back into a period of, hey, we got to do something about healthcare. And the difference in this period, which I think the governing board is quite aware of and taking seriously, is the costs of healthcare are really driving the debate. And at the same time, after the really kind of inexcusable and horrific act of political violence that occurred with the murder of Brian Thompson, it did sadly reveal the amount of antipathy toward insurance companies that exists out there. And policymakers need to take that seriously, because if there is this amount of cross-partisan anger at insurance companies, to the extent that they say favorable things about a murderer, we're in a different situation. And we've got to understand that as we condemn the violence, we have to understand what it has revealed. And so I think those two things, combined with this dynamic in around the actions by the Trump administration to curtails key functions of the federal government, including key functions in healthcare, in National Institutes of Health, Health and Human Services. These programs are being scaled back, and people are coming to a new understanding, in many cases, that government does play a positive role. And as Rebecca, you said, we've confronted a real negative view of government for decades. And many people still hold that, but others are looking at government perhaps in a different way. So what I think the key difference between kind of the advocacy work that I've done and others versus the work of your committee and the governing board is that you have a real opportunity to listen in a deep way, and we have to as well. But as Rebecca said, we're often talking about advocates, we're often persuading, and maybe don't have as much time to engage deeply in how people describe healthcare and their experience of healthcare, and what their own desires are for a transformed healthcare system. Because even though there may be opposition, and the key points again that Rebecca pointed out on healthcare reform, there has been consistently, really since the ACA at least, and maybe going back to 91, 92, a recognition that there needs to be a systemic change in healthcare. And that belief in systemic change provides an opening, I think, for your work to understand what do you mean about that? And often what it comes down to, and one of the key frames that have been successful for us has been health security. People really want to feel that they are secure. a lot of folks who are insured still have deep concerns about healthcare because of their fear that they will not have adequate coverage when they need it. And they will say, "Yeah, I'm." You'll see strong majorities for people to say, "Yeah, I'm satisfied with my insurance, but I'm not sure it's going to be adequate for if I really get really sick. I'm not sure I'm going to be able to afford the care that I need, and I'm very concerned about others who do not have as good an insurance as I have." You often hear those points, and I think they have to be taken quite seriously. We also have found that the frame of guaranteed health care is very popular, very effective. When a survey was done in California of low income Californians, those making under 250% of federal poverty level, over 2/3 supported and they literally said this, a government run healthcare program that ensures that everyone will have coverage. So that tells us that there is a certain dynamic in play where people feel like some others are getting a better deal, in healthcare. And you might even hear this from middle class workers who say, "Hey, the poor are taken care of, whether it's Medicaid, the Oregon Health Plan, but I'm having to pay all this money." And so what we're tapping into, I think, is a dynamic in contemporary society where there's a certain level of resentment. And we need to overcome that with a program that says, we're all in this together. We will guarantee everyone gets the health care they need. And so guaranteed health care in that sense has been very popular. Of course, similarly, single payer as a descriptor is confusing to most people. It's technocratic in a way, policy wonkish, if you will. And some people feel like, oh, am I the single payer? And so we don't want necessarily them to think that. And that's why we've used Medicare for all. But of course, Medicare has been eroded as a benefit, and many seniors have trouble affording costs under Medicare. So that's somewhat less helpful as a descriptor as well. In California, when we were dealing with the legislature and trying to pass our version of SB 770, which set up a similar process to the governance board, they were not enamored with single payer. They felt it had been either misunderstood or confusing or tainted even politically. Ultimately, they really came around to, through the Healthy California for All Commission, similar to your task force, the descriptor unified financing. And that, for many advocates for a single payer system, is problematic politically. So what we find, and this is my last point, is that different audiences are going to respond to this in very different ways into the description. An audience that's very committed to the issue and familiar is going to be fine with single payer Medicare for all. They know what it means, improved, expanded Medicare for all at the federal level. Legislators, not necessarily. And certainly when you start talking to labor union members who have very good health care, they're going to want to know, as Rebecca said, hey, is this going to be as good as what I have, or is it going to cost me more? And obviously business are going to have a whole different set of concerns. And then of course the hospitals and providers and the insurance companies. So all of that, I think, speaks back to the point that you all are in a position to deeply engage with these constituencies who have not been reform advocates. And that would be a huge, I think, contribution to understanding what it takes to actually win this policy, because we're all going to the ballot. Well, at least Oregon and California are going to the ballot. And your work is going to be instrumental in figuring out how we broaden this support into those key constituencies.
Yeah, I'll just follow up really quickly on that. And because we've grappled with the single payer phrasing too, because yes, that's a phrase that, again, if people don't understand what it is, there's this like kind of weight around it. On the other hand, what we've thought about at HCAO is that single payer likely is the direction, or at least it's the direction that the governance board, it's what was mentioned in the task force recommendations, as this is our recommendation to do single payer. So assuming that that is the path that the governance board takes, we also want to, again, speak honestly, plainly, openly about what that is and what this direction is. So with HCAO, we don't want to hide or pretend like single payer isn't something that we support. That is. So we are, using terminology that is, again, less freighted with misunderstanding. If everyone understood what single payer is, absolutely, we tattoo it on everything, and there's nothing problematic with it. But because of that history, we are kind of using this more neutral phrasing that lets people interact with the concept in a more open stance. But we are ready, willing, and able. On our website, we mentioned single payer. We are going to launch, or redoing our website right now, and we're going to have a whole section explaining what's the difference between single payer, multi-payer, public option. What are the pros and cons? So I think the governance board has to be ready, as Michael mentioned, firstly, due to that deep listening. If you're doing town halls, it's not to come and present what the governance board is doing. It's first to ask things like, what does quality healthcare look like to you? What are the challenges you currently experience with healthcare, with the healthcare system? Actually, an example from global health comes to mind. There was a program in Senegal trying to improve women's health, but it was an issue that kind of came up against certain cultural beliefs and practices in the country. But instead of this kind of foreign NGO coming in and telling the local community how they should do it better or how they should change things, they started asking women in the community, what is not working for you? What are the things you are afraid of around this issue? What are your concerns? And then they showed them how their kind of proposal addressed those concerns. And so that's, I think, a general strategy to go in with, opening up the conversation, what doesn't work about this current system, and showing how what the governance board is proposing is set out specifically to improve that, because that is the work that you're doing.
I would just quickly add, Michelle, one of the alternatives to single payer, because of course we blast it all over as well, is describe what we're talking about. High quality healthcare that costs less, guaranteed, or just high quality healthcare that costs less. Then when we want people to understand, you get away from maybe what's seen as a little bit of jargon, right? And just talk directly about what it means. You can go to any doctor that you need, right? There's you're not going to pay when you are getting care. You've already paid, right? And I think something we talked about, the other day that both of our organizations are really committed to is not just talking about policy, but talking about values. What is the value, what are the values that we want to, for the healthcare system to be based on, right? Caring, compassion, community, really making it clear that those are the things when we talk about a transformed healthcare system. It's high quality, it costs less, and it enables caring. And it's based on compassion. And it's part of how we build community. The truth is, if you look at the surveys of countries with national healthcare systems, it is a bedrock of their sense of social solidarity. And there are certainly many people who believe that our country, which is more individualistic, lacks that. In part because we don't have that kind of healthcare system, and people feel like they're on their own, and it's whatever you get all the healthcare you can afford rather than all the healthcare you need. And it also, of course, makes it somewhat difficult to develop a national healthcare system when when folks are overly individualistic, and we confront that. But I think we confront that by making these value statements that people generally agree with.
I love that you said that. There's a health economist Gavin Mooney, who used to always write that a health system, we think of a health system as this kind of, set of logistics and mechanisms that deliver healthcare. But he was like, no, it's first and foremost, it's a social institution. It's a representation of social values. And, do you think that a child of a poor family, a low-income family, should not get care, whereas a child of a wealthy family should get access to that care? It's just this simple question. And that kind of values discussion, like, again, if you're having town halls with them, can be a really effective way of bringing people together on that. I also, I mentioned things, that the concern of like, well, I don't want my tax dollars to pay for someone else who's making bad decisions. I mean, there are some answers to that we always find very effective of, the bad news is you already are, but you're paying for the most ineffective, expensive, worst version of it through our emergency rooms. When someone doesn't have access to insurance, the emergency room is the only place they can go and not be turned away by law in our country. But so our tax dollars are paying for that system. But again, people are going at the latest stage when they're desperate, and that's the most expensive time to treat it. Whereas shifting to this system means people can go and get preventive care early on when it's cheaper, so even if there's not an ethical call to we want them to get preventive care because it's ethical, just from a cost effectiveness perspective. So learning to, again, anticipate the concerns and questions and be able to answer through the values of, different potential audience members is an important exercise. I think that this committee should work through.
And that reminds me, Rebecca, that we often talk about healthcare should be like firefighting, that, you don't have insurance for a particular fire company. It's a public good, right? You get fire, protection when you need it. And it's something that just is part of what makes our community livable, is to have that service available to whenever you need it. And that I think still is the right metaphor, or comparison, really, not a metaphor. It's real. It's the right comparison, I think.
I think we'd probably both be happy to share, HCAO, and I'm sure, Michael's organizations have kind of worked out some of these responses. They're not even rejoinders, but they're kind of opening up I get that concern. I get that worry. Think about it this way, or, this is how one way to look at that. And we'd be happy to share that information kind of with the board, to the extent it would help.
That would be great.
Yeah, we would love that. And I think that's one way that we can build on the work that has already happened. We don't want to reinvent the wheel. We want to build on it. We want to move the ball forward. So thank you both for everything you just shared. I took a bunch of notes. It's really helpful. We started this conversation last month with Patty Wentz around strategic communication and how to frame things so that we do no harm. And we open up an opportunity for authentic engagement where people can share their thoughts on what we're actually proposing and not their thoughts on a piece of jargon that's been defined in the media or on social media or what have you, for partisan political purposes. So this has been really helpful to hear what frames and ways of talking about this work has you've seen work on the ground in real time. I also hear that we're all getting matching tattoos that say single payer. That's the case, right, Rebecca?
After it passes, we can do that.
Okay, all right. Great. So I'd love to open it up to the committee for questions and reflections. And go ahead, Craig, start us off.
Thank you. Hi, Michael. My name is Craig Newton. I reside in Medford. Hey, you made I was looking something up when you said, I like the term you used. I think you were comparing, let's say, Canada to US. You were saying how we're more individualistic. And you said the other countries are socially, what was that second word? Cohesive? I can't remember. I like that term. I wanted to write it down.
Yes, you're putting me on the spot, Craig. Yeah, I mean, it is so. I think cohesive is the word, right?
Okay.
That they are more socially cohesive, and there's a greater sense of social solidarity.
Maybe that was it. Cohesive is all, okay.
Yeah, that's what a lot of folks say. I mean, that's what the sociologists have found. through research, is there is a greater sense of social solidarity, and healthcare is foundational for that in these other countries. Clearly, you see it in the UK. It's been a bedrock of their society since just after World War II, and there's been a lot of it's a cross-partisan issue too. And that's what we find here when you start talking about this issue. Similarly to Rebecca's experience, we talk to voters in districts represented by Republicans, and you can get into these conversations and find out people really crave the security that universal health care would provide. It doesn't necessarily translate in California to votes in the legislature by non-Democrats. But that doesn't mean that those voters aren't open to this messaging and open to that sense of security and community that a system of guaranteed healthcare provides.
I don't want to hog all the time, but it's always perplexed me, flummoxed me, as I've argued with relatives, friends, coworkers over the decades, how we all know this, conservative people are so patriotic, and I always try and use that to tell them that this is patriotic. It's you're helping your fellow man, your fellow American. But I understand immediately they go to the individualism. I understand that. I'm trying to use that patriotism to connect this to alter their thinking. And one more thing, folks, I was looking back at my notes when you were talking, Michael, and that's why I was half paying attention. And at our February meeting, we had someone speak to us, and this was a suggestion given from public testimony at our meeting. Someone said that this scored well with the public. It was Family and Business Health Security Act. Now, I may be off a little bit, but I'm just mentioning that because you're talking about single payer. And I remember during that meeting, they said that didn't score well. So anyway, thank you.
Sorry, Craig, we put an initiative on the ballot back in 1996 called the Health Security Act. And so health security has been a frame that has proven quite popular. That ballot initiative did not do so well for other reasons. But I think that's something that we should be quite aware of and use.
Great.
I was going to say two quick things on that. Just, as a professor, I love to throw around things like social cohesion, social capital. But speaking to people in the public, it's more effective, I think, to talk about like, do we care if our neighbor's child can get health care? We're talking about our neighbors, our community, the people across the street. So that can also be an effective way, like rather than using the kind of social solidarity, I think that works for certain people, but the term solidarity can even, if someone is rooted in more of an individualist perspective, then solidarity might not echo with them. So I think what that last kind of exchange really brought up too is like, speaking, like recognizing what are the values of the people who you're talking to. So freedom might be a very effective word. So imagine in the system where you are free to go to any doctor. Now, again, we don't know, like, universal healthcare systems are different. So in the UK, you do have to go to a general practitioner first, and then you get referred to a specialist. In Taiwan, you can go to any doctor in the whole country from your first visit. So we don't know how that will be designed here, but yeah, imagine having a broader network where you have the freedom to choose the doctor you want to go to. Imagine the freedom of not having to worry about bankruptcy or whether you can afford to pay for your healthcare and your child to go to college. So thinking of how, we talked about certain terms that can shut someone down, but what are the terms that like engage people, and how do you apply them, again, truthfully, genuinely to what this policy would mean?
It's very funny, Rebecca, because when I testified to the insurance committee at the Texas legislature, you will not be surprised to know that all I talked about was freedom. Didn't get the bill passed through their committee, but it resonates. It really does. And people feel quite, I think, constrained by the current healthcare system. And there are these worries about whether it's sustainable, whether it's going to be there when they need it, as we talked about. And I think it's the freedom to change jobs, right? Because you're so bound by your job because you got to keep your health insurance. I think that's a very broad experience, right? So I really agree. And there are a lot of, and again, that's why we say community say instead of solidarity. Solidarity is kind of a, more of a left frame, if you will. Community enjoys broad support, right? So I totally agree that we found that some of those words, those value words, can really translate and open folks up to to this reform who might not otherwise be.
Well, and one thing I'm hearing really emerge from this conversation is that dropping jargon, using language that invites engagement is an accessibility practice, because we, as a board, we're not just nonpartisan. We want to hear from people across the political spectrum. We want to hear from Oregonians who support, who oppose, who are political, who consider themselves non-political. We genuinely want their feedback, and we can't get that feedback if we're using jargon that immediately shuts down the conversation. And so I think that is really helpful. And then also hearing that, even if we start with these open-ended frames and have an engagement and a conversation, we also need to be extremely transparent. So at some point in the conversation, we do need to say some people might call what we're discussing single-payer healthcare. And this is how it works. And just so that there's not a feeling later of betrayal, or like there was, I didn't realize that's what they were talking about, or something like that. So I think that that's really helpful in terms of thinking about how to engage. Other questions on the committee? Michael, did you have a quick response? And then I want to get to Colin.
Well, I just quickly, yes, absolutely, it's single payer. But that's why we use the example of firefighting. We would pay for healthcare like we pay for firefighting. So again, the descriptor, right, is quite useful.
Hi, I have two questions. The first is just to Michael, really, because I can understand that you're pretty plugged into what's going on in California. And you mentioned that in Oregon and in California, this issue will go onto the ballot. From my understanding of Oregon's path, it's going to be, we get the final plan in 2026, probably vote in 2028, but maybe 2027. Can you talk a little bit about California's timeline, or what's going on down there?
Well, it is going to depend, maybe in both states, on whether the federal government engages with us in discussions over federal support and waiving certain provisions of existing law so that we can pool the money that the federal government pays for healthcare in California into a trust fund that can pay for all healthcare services, or those designated. So those discussions probably are not going to happen until after 2028, as it looks like. And what would happen, there are two ways to get on the ballot in California, like in Oregon. You can have a citizen petition that puts it on the ballot, or you can go through the legislature. Our view has been that we should try to go through the legislature. And the reason that we have to go to the ballot in particular is that there are constitutional requirements for voter approval of taxes. And so the taxes have to go on the ballot no matter what. And it's not, it's not an easy threshold to get the legislature to put those taxes on the ballot. But that's what we would prefer to do. And there are different arguments about whether that takes a 2/3 or a simple majority. If it takes a 2/3, then we're probably going to be in a situation of having to collect petition signatures. The earliest we could get on the ballot realistically now is 2030, probably.
Okay. Yeah, that's good to know that timeline. I hope it's faster, but whatever, here we are. And the other question I have is for both of you. And I don't, okay. So I intuit that this eventually is going to be a really huge topic for our country. Like this specifically, what's happening in Oregon, I think is going to be, I'll be surprised if the next year and a half goes by and there's not a lot of attention, right? And in the same way, it's kind of impossible to be neutral. Like we as a communications committee want to be nonpartisan and neutral, but it's a pretty, it can get a lot of people really upset, this whole conversation. And what can we do to prepare for that? If it never happens, we won't have to worry about it, but what can we say to people that are worried about the coming firestorm? Or what can you say to me? I'm worried about the coming firestorm.
Could you speak a little more about what the firestorm? So many firestorms.
That's
right
true.
now.
I just can't imagine that this work that we're doing will maintain this current level of sort of like low burn, low
like
engagement.
There's going to be some blowback, or the opposition will come out in a way that they aren't right now.
Yes, and I think that it will potentially come under national scrutiny, right? Because it's the first state to make this, to try to escape from our broken system, right? And to make something that works. So I'm worried about it, and I'm worried about the conversations and even how to talk about it.
Go ahead, Rebecca.
No, Michael, please.
Well, to me, one of the interesting openings that's presented by what the Trump administration's doing is they're preparing to throw a lot of healthcare decisions and policymaking back to the states. And that's, along with a reduction in the amount of money they give the states. But the notion that states are going to take the initiative is, for people who might obviously be inclined to the opposition, a positive thing. And so people can understand, well, Oregon is going to have to take control of our own healthcare destiny. Because of all the changes at the federal level, Oregonians are coming together to figure out what kind of healthcare system is going to work best for us. And I think that's a very powerful frame. What's going to work best for us as Oregonians? And I think the other piece of it is that don't overestimate people's attachment to the present system. You have not seen a partisan distinction in the reaction to insurance companies that we referenced earlier. There is broad cross-partisan anger at the insurance companies, at the claims they deny, at how they limit our choices and the costs that are incurred. So I would not be on the defensive on that. I would say, yes, the system doesn't work. It doesn't work for Oregonians, and Oregonians are going to fix it.
Yeah, I do think, the pharmaceutical companies, the private insurance companies, we have not seen kind of paid advertising or a messaging campaign around this, but it will come. It is inevitable. The goal though isn't, we don't have to convince everybody. It would be nice to, because what is powerful about this is that it will help everyone. Like it's going to help people who will be opposed to it, just off the bat. And so I think as we talk about this all the time, we have to keep with that message, that positive message, and that and the recognition. I think, as Michael pointed out, like the post the United Healthcare event, the anger and rage and upset at the current system at private health insurance companies is so palpable right now, that's always, we can always refer to that, to say, look, this is a new system. We understand that this is, brings up a lot of questions and fears. That's normal. That's why we're here to talk about this. But one thing, we can also talk about is, how is the current system when private health insurance companies routinely deny your care, and you don't know when you're going to get denial, but they routinely deny your care to maximize their profits? Does that work? Can we talk about, does this system work? And no one, people are not going to say yes, that system works. So now that we agree that this system doesn't work, that maximizing private profits is not something that should be applied to healthcare, well, what are the alternatives? This is the alternative. And you know, the fact that we are the last industrialized nation, I mean, I think that's so interesting that people don't know, that they think this is a left radical idea when we are the last country of wealthy nations to move in this direction. So this is the most standard, boring policy that exists in all these countries. So just having those messages to inoculate. Again, as I said, when I opened up, we already know what the blowback or what the opposition is going to say. There's like 3 or 4 things they can say. And I think we have really substantive responses.
Great. Thank you all. I am wondering if there are other questions from the committee members. And if you have to be off camera, that is fine. You can raise your hand or you can just unmute if you have a question. And really appreciate this conversation. This is Fred, by the way. He is also enjoying the conversation, as you can see. One thing I'm curious about is, you know, I have a background in community organizing, and in my experience, when the jargon is dropped, when we're talking specifics and impact in the community and what we're experiencing, political and other differences just fall away, right? Like it's such a human experience to be in a conversation and a dialogue like that, and I love it. And I have found that when I approach those conversations trying to convince somebody with like that as my end game motive, that doesn't happen. Like that, it's not possible to create that container for the open dialogue and the conversation because I'm not actually listening and they can tell. But if I approach the conversation, we're letting go of whether they agree with me at the end, letting go of whether I hear what I want to hear, that changes the dialogue. And I'm curious if that has been part, aside from the word choice, aside from the framing, aside from the format, what are your experiences with kind of that orientation or that intention for the engagement?
Well, it's a really great example, Michelle. So I work with this organization, People's Action, which is doing a campaign around claims denials. And they do also canvas work. And they'll do canvas around the election. And then they do what they call deep canvas, usually not around elections. And the deep canvas approach it, as you said. It's an open-ended conversation. What are you concerned about? How's your family doing? What are the issues that are really affecting you these days? And that conversation is very, very different from the persuasion conversations at the door. And I think that is, again, to emphasize the value that we have is time. We do have a couple years to get this right before we really have to advocate for a proposal, right? And so you all are in the position to do that work in a very unique way, in a way that would be hugely impactful to this effort to transform our healthcare system nationally. And I would really encourage you to engage in those open-ended conversations. Town halls, if they're speak outs, if they're opportunities for people to talk about their experiences, are great. Not to hear from the podium, but to tell the podium, here's what I'm going through. And having those, located in not a, maybe a traditional setting, but go to a venue near a community clinic so that you bring folks into that discussion who use that clinic and they talk about what their experiences are in healthcare. That I really just think those conversations, and always at the doors is most effective, can provide the substance, right, for what ultimately are the messages that the board would want to adopt.
I appreciate that
I
reflection.
would add too,
Go ahead.
yeah, a good practice is to, if you're doing a town hall or whatever the method you use, is to ask people first, like, what are your questions? what do you want to know about this? We are we're hosting this conversation so that you get your questions answered. You walk away feeling more educated and informed about what's going on, and that we are listening to you in that way. Also, you then get to anticipate, like, what are the things that people are going to be asking. So that's one thing. Also, you mentioned something. Sometimes town halls, and we're seeing that happen in a certain way, can just become like a shouting match. Like someone is there's the presenter, and then there's the audience, and you doing town halls in different settings, you might have a very friendly audience in one setting. You might have people who are wanting to come and shout at you. And I think there are certain things, again, the choice of method, we can talk about this offline, but there are certain things, having small group discussions in the beginning where people kind of have to get to know each other as human beings. So whether there's icebreakers, I know all my students like roll their eyes when I make them do an icebreaker, but it's because we know that when you're talking in small groups with people who are humans, and you're talking about your kids and your dogs, and then you find out later you may be on a different, spectrum, it's harder to dehumanize and kind of just get riled up. So there are things like that of building community, even in whatever method you choose, that could be helpful. But again, we can go into depth in that on another setting.
Thanks, Rebecca. I know this is hard. We're picking your brains on like your life's work, and then we only have limited time. So appreciate you. Go ahead, Jensina.
So by day, I'm an EMR trainer, and I work with doctors and their staff, training them how to use their computer system to make the electronic medical record happen. By night, I'm Batman, of course. You've never seen me and Batman in the same room, so that's how that works. I'm always amazed by the physicians who have actually practiced in other countries or during their process of medical school are so aware that this is the better way to do it. Many of the physicians I've worked with have spent a year working in Australia or any of the other countries where they're used to this, and they talk about how much more stressful it is for them to come to the US and try to fall in line with all of the value-based care and pay for performance programs, and how every single payer has their different regulations. So you can get a 0.5% bump in reimbursement and things like that. I am curious though, because most of the audience that I work with is physicians. What sort of language do you use when you're talking to physicians? The ones who are, yes, to us, it seems like it's slam dunk, it's a win-win. What could they possibly object to? But maybe what sort of concerns have you heard from physicians?
My experience with physicians is that it's changed dramatically over the last few decades. And there's a generational divide as well. That essentially younger physicians overwhelmingly supports this, what we're talking about as a kind of single payer universal healthcare system. There is tremendous support among med students and young physicians for this reform. What's happened is that the base of opposition, which was essentially doctors in private small practices, are gone. Doctors have become employees. They have become increasingly controlled in how they practice, exactly as you say, Jensina, through the reimbursement protocols of insurers. And so they feel like employees, and that's not what they went to med school to be. They went to med school to exercise their professional clinical judgment. And that's what we talk about. We talk about this, it's not a government-run healthcare system, it's a provider-run healthcare system, because we restore the ability of providers to practice as they were educated to do. Nurses, nurse practitioners, physical therapists, MDs. And what physicians are primarily worried about is, am I just going to get paid less under a national healthcare system? Because in fact, in all the other national healthcare systems, physicians are paid less. What's beautiful though in that regard, in the current reform period, is the focus on reducing administrative costs and not reducing physician salaries or reimbursements. And so we're able to diffuse that argument to a large extent, because a lot of the official work on cost and financing makes that assumption that we're going to not go after provider rates. We're going to control hospital reimbursement costs. We're going to do things on the cost control side that we have to do, but we're not going to be doing a wholesale reduction in physician pay. And that's very important, I think. But ultimately, the physicians are going to respond to the arguments, I think, that are kind of unique to their experience. They're not necessarily going to respond to a lot of the other arguments, but they're going to be very responsive to how are their working conditions going to be better. And can we make a convincing argument that their working conditions will be better and their pay will not be adversely impacted and they will be able to provide the care that their patients need. Those, and I was in a meeting with a medical director for United Healthcare, and this physician just laid out their actual experience of what it takes, 3 hours on the phone to get a claim, approved or a claim denial reversed, the steps they have to go through. And the medical director for the insurance company was clueless about what it actually takes. And so if you can put those experiences in front of other physicians, right? I mean, they'll say, yeah, me too. And I think it's very compelling.
Thank you.
And also peer-to-peer. If you get physicians to talk to other physicians, that's the most effective message. That's who they're going to trust. I do believe, I don't know, maybe I have older information, but I thought the governance board was talking about like Medicare level reimbursement, which is a little lower than private health insurance, but it's not Medicaid. So most physicians have no idea what the actual numbers might be, and they're afraid that oh, this is going to be Medicaid level reimbursement, which hospitals suffer, they can't cover their costs. But that's not what the governance board has been talking about. Medicare level reimbursement levels are very reasonable and good, and so that again, this was like 6 months ago, so this might be outdated. But yes, that the AMA used to be, in the 1920s, 30s, they were the biggest kind of anti universal health care, but it really was about pay. And right now, yes, understanding that the stories abound of having to, I just saw a doctor online she was talking about having to leave a surgery. She was in a surgery and had to leave to spend time arguing with the health insurance company because she had another patient who, advanced cancer, needed this treatment. And this was the moment they had to make the phone call. It's dystopian. So hearing from doctors what they're having to navigate with these pre-authorizations, that's something Medicaid, they don't have pre-authorizations. Pre-authorizations, which is denials to save money, is something that was invented by private health insurance companies. And so that is also something, a free, hey, physician, do you want to be free of having to navigate, having to hire staff, if you even have a private clinic, from having to hire staff whose sole job is to argue with insurance companies?
I think you make a very good point, Rebecca, that doctors' experience under Medicare is pretty positive in general. They don't necessarily have a problem with how Medicare treats them, the reimbursements come. It is true that the reimbursements are less than commercial insurance, but what it takes to get those commercial insurance payments obviously is much harder. So it often works to talk about doctors' experience under Medicare.
Great. We are getting close to time. Do you have another quick question, Craig?
Yeah, it'll be very quick. Something Michael mentioned earlier concerning, I understand the current administration is against the Affordable Care Act and single payer, but I wonder if you could just tease this out. Let's just pretend that the state of Oregon puts on the ballot single payer, we pass it. How can the federal government, if they believe in states' rights, how can they come in and then say you can't initiate that? Is it because of, would we be getting federal funds, or would it be completely self-contained? The state of Oregon would be the citizens paying for it itself. I was wondering if you could elaborate on that. Thank you.
Well, yeah, I mean, the federal funds account for a huge portion of healthcare spending. more than half of Medicaid. I'm not going to be able to quote the Oregon numbers, but it's generally true that, between Medicare and Medicaid and the Affordable Care subsidies, and that is the subsidies that are used to help people afford health plans on the Affordable Care exchanges, the Children's Health Insurance Program, leaving aside the VA and the Indian Health Service, and also the fact that employers get a tax benefit for providing health insurance instead of in lieu of wages. So there is just a huge amount of federal spending that goes into a healthcare system, and the only way to capture that in what we envision, of course, is a single fund that then pays for healthcare services. But you can't put those monies into that fund without the federal government's approval. And there are waivers under Medicaid, under Section 1115 primarily, and there are waivers under the Affordable Care Act, Section 1332 primarily. And so you can't, I've talked with Republicans about the issue of states' autonomy and universal health care and the approaches, state innovation, as we like to call them. And it only goes so far. And there's an act in Congress to actually expand the waiver opportunities for states. The first Trump administration tried to limit any waivers under the Affordable Care Act to exclude single payer type universal healthcare systems. So there's history here that's not favorable to us with this administration. It obviously the political momentum and so forth can change that dynamic. So we shouldn't give up. There's no reason to give up, but we should just recognize that there are some legal barriers, right, to capturing that federal money that ultimately we're going to have to confront. And unless the administration changes, we may not be able to do so until 28, after 28.
Thanks, Craig, for that final question. That definitely relates to our work. And Amy, I see that your hand is up as well. And then I think we'll transition.
Okay, yeah, I just wanted to add, because I'm not sure kind of our committee's kind of awareness on how skilled Oregon has been since the creation of the Oregon Health Plan and expanding other programs at really drawing down that federal Medicaid money and how many different things are dependent on it. And so that's really going to be something that we're looking at. The reason that we have so many people covered in Oregon is because of our waivers, and that through the Affordable Care Act, we use Medicaid money for things like in-home supports for disabled people, and other things beyond just basic health care that we're very dependent on. I was on projects 15 years ago on kind of like Jensina, expanding electronic health records and safety net clinics that was using Medicaid money. So Oregon has been very skilled and dependent on Medicaid funds, and that is something we're going to have to wrestle with for sure. But that's all I wanted to add to get a little more Oregon specific.
Thanks, Amy. It's a great point. Yeah, we definitely don't want to have people lose coverage or lose funding that Oregon currently gets to cover people. So lots of complex things to unravel, but that's why we're all here. So really want to thank Michael, Rebecca. You were so generous with your time and your experience and your expertise. We hope this will be a long-term partnership, thought partnership with both of you, and just really appreciate your work and you coming and sharing it with us today. I know our committee also appreciated hearing from you all, and this recording will be available online as well for folks who maybe missed this that you want to share this with. So thank you, thank you, thank you.
Well, thank you so much. Great to have this conversation, and look forward to continuing it with all of you. And great work, everybody. It's so important, and we're cheering you on.
Likewise, thank you so much for having me, and I definitely look forward to ongoing collaboration. Thanks so much.
Wonderful.
Thank you.
You're welcome to stay if you want, but if you need to go, we understand. Thanks again, and I'm going to turn it over to co-chair fellows.
Yeah, I think that conversation, I think probably got us thinking about a lot of different things. Wanted to take us back to our last meeting a little bit where we got to meet Patty Wentz and just kind of offer space for any thoughts that people had after that conversation, you know, kind of connecting our conversation with Patty with what we just heard. Give you a little bit of an update that we are currently working on a statement of work for Patty to work with us and our committee and the board. And that once that's finalized, Michelle and I will be starting to work with Patty kind of about our next steps with her in April. So just wanted to hear your all thoughts about our last meeting, Patty, strategic communication, and just anything that came up for you. We can kind of blend maybe now and if it's okay, co-chair Glass, kind of blend the meeting reflections since we just heard from them with meeting reflections from Patty and just kind of do that all right now if people have thoughts that they want to talk about. Yes, Jocelyn.
Yeah, I thought it was really interesting to see the through line between both these meetings. I really appreciated both of them highlighting like getting away from jargon and data and then like bringing it back to a more human level and like storytelling. I know I've gone caught up with wanting to like when I'm having discussions with people about this, being like, oh, well, this data point and this, and you know, we spend this much money compared to this, and that just doesn't seem to be as effective from what I'm gathering as, you know, connecting with someone on a human level and then kind of like storytelling about your own experiences as well. So I thought that was really helpful.
Yeah, and I think part of the strategic part is like which of these strategies work best for which audience, right? And that's really honing that. I think what we just heard was more focused on our conversations with the public, or, you know, there was a little bit of it that was very like when we're talking to providers, which is one of our focus groups, you know, understanding which strategies for which audience is going to be really important. Are there other comments or questions or thoughts, Colin?
Just echoing that I think it's great that Patty's going to be more involved and looking forward to however that relationship works out. And I think something that's coming up just hearing Jocelyn speak now is like the task or like the big job of being flexible. Like I hope to, and maybe we all do, like hope to be able to speak to physicians and people on Medicaid and, you know, everybody, right? And so like in the span of a 20-minute conversation, depending on who's in the room, like being open and at a human level with all these different humans with all these different experiences sounds really hard, but I'm glad that we're learning how to do it together.
Thanks for that reflection, Colin. I think that's such a good point. And I think that the other thing that came through so clearly and really clicked for me in listening to you all discuss this with Michael and Rebecca is that we're not doing that for our purposes. We're doing that as an accessibility practice. We're doing that to facilitate a dialogue with people and respect where people understand and respect where people are coming from. And I think that that is really helpful, and it's different than how a lot of times strategic communication is presented, right? Strategic communication choices are often presented as like a way to manipulate people. But really, I think what I heard clearly today and what my values are, and I think our task as a government body is to make sure that we're presenting information and having a format and a container for a conversation that is going to allow people to participate and feel respected and heard. And I think that that's exactly what you just said, Colin. And I really appreciate you bringing that point forward.
Craig?
Thank you. What I got out of this is the byline or the connecting of the two meetings is that we're eventually and obviously as a group going to have to come to an agreement as the type of buzzwords we want to use when communicating and how we want to frame this universal health care plan, because according to the speakers today, single payer is fine, but I have a note here, like I mentioned to all of you, you heard me read it. They said that the last meeting in February 26th, that single payer was off-putting, people didn't like it, and people responded positively to Family and Business Health Security Act. I know that's a mouthful, but anyway, what I'm getting at is eventually we're going to have to come to a decision as a group that we can speak in a unified voice, and we have certain buzzwords or words that we think are effective and won't push people away. Thank you.
Yeah, that's really important. I think from the last time that came from a poll, I'm blanking on the name of the Oregon organization that did that polling in terms of the single payer not being as favorable.
Yeah, that was the Oregon Values and Beliefs
Yes.
Center. And
Mhm.
and I think that the speakers agreed, Craig, actually that doesn't poll well, and that's not what we should lead with, but that we at some point do need to maybe mention it, because otherwise we open up a kind of a gotcha, right? If we never mention those words and then the insurance companies run an ad and say, you know, this is single payer healthcare, then people might feel like they were misled. So the importance of transparency, but not leading with that like very inaccurate, but that those terminology pieces of jargon that may be more emotionally loaded and bring something to mind that's not what we're talking about. So there's like a little bit of a nuance there, but you are right.
So Michelle, did you mean that? So did that? Forgive me, folks. I have a horrible memory, and I attend a lot of meetings, and things kind of leave my mind after I leave a meeting. Did that poll good or bad? That Family and Business Health Security Act, was that looked upon positively or negatively? Thank you.
I'd have to check on that term. That is what the public comment was on, that I think that you're referring to. What I was saying was that you are correct in that I think Michael and Rebecca agree with the polling that we have from two different polls. One is from the Oregon Values and Beliefs, and one is funded by a former board member, Warren George, that agreed that single payer is not a helpful frame, that it actually leads to misunderstanding of what we're talking about and increases opposition for the plan.
There are other comments or thoughts I want to make sure also, just because we have a couple public comments coming up. And I also want to make sure that if anyone, committee members have any updates you'd like to share, that we cover that as well. But if anyone else has kind of thoughts about what we just heard, our meeting with Patty, thoughts about working with Patty going forward, I want to make sure we get that in before we move forward with member updates and public comment.
I just want to say I was very impressed with both of them. Great credentials, great people, easy to talk to. I liked they spoke in everyday terms. I thought they were both excellent. I just wanted to say that. Thank you.
Yes, agreed. Any other comments before we move on, or if you have a committee member update that you'd like to share? Jocelyn?
Yeah, I just wanted to plug an event for Healthcare for All Oregon. We're starting a Central Oregon chapter, and we have our first event. It's going to be in Bend, Oregon, April 29th, at Commonwealth Pub, and there'll be drinks and music and snacks, and I think they're going to have a couple people speaking too. So it's going to be a really fun event.
Great. Colin?
Yeah, we're excited or I'm excited, and HCAO is excited for that Central Oregon stuff. Yeah, there's lots of things happening in Portland. I wanted to do a plug for our annual Healthcare for All Oregon's annual conference, which is on Saturday, June 7th. So we'll have time to discuss it again in May, but if folks are available and interested to mark your calendars it's like our annual member meeting. And so there'll be some sort of voting among the Healthcare for All Oregon members, but it's mostly like a conference to talk about this universal healthcare reform. Yeah, so that's in Eugene, Oregon, and we don't have an itinerary like yet for what happens that day, but that's on Saturday, June 7th.
Great. Michelle?
Thanks, y'all. It's really exciting to hear about these upcoming events. This is retrospective, but I wanted to share that I was able to respond to a request that came to the board to have a board member speak to Healthcare for All Washington at their Wednesday, I think they have Wednesday meetings twice a month, member meetings, and got to chat with about 60 folks, mostly from Washington. There were a few Oregon folks on there that I recognized as well. So it's great to see that synergy and crossover is happening in this multi-state effort. But was able to give an update on our work, and they were particularly interested in the fact that we had a committee doing community engagement and communications work, because that is fairly unique to have that infrastructure for this piece of the work built into these types of efforts. And so just wanted to let you all know, I think the recording will be up on their YouTube channel soon. But just wanted to give you all a shout out, because this was one of the pieces that they were particularly excited about and wanting to learn more about, so they could see if they could replicate it as well.
And Jensina, do you want to with me talk about the March 1st event? I think we shared that it was going to happen, but we haven't shared the results
1st?
of the, or did I get the date wrong? The Eugene, the
Oh, the
panel
healthcare
that you
part.
hosted?
Yes, sorry.
Yes.
I
That's
was like,
okay,
what
yeah.
are we doing next year, Amy? Yeah, so we had about 200 in attendance, and the link is now online for the YouTube recording. We combined it with the NAACP Health Fair, which now looking back in retrospect was a little ambitious, because it ended up for folks having to decide whether to hang out for 5 hours or not on the first sunny day of the year. But the conversation was excellent. Valdez Bravo, the president of Healthcare for All, was super inspiring. I will put him on a stage in front of any crowd. It was amazing listening to him. Senator Manning, of course, had a lot of the background of why the Universal Health Plan Governance Board was created and how it's been developed and how the funding is anticipated to continue. Having Amy there to actually talk about the work that UHPGB is doing was really fantastic. And we got good feedback from the event. It was interesting. Some folks thought actually it was too lighthearted. They said that it didn't really paint the picture of the dire, desperate need that we're currently facing. And so that's certainly something that the forum planners will take into planning the next event.
Thanks. Yeah, it was a lot of fun being there that day. Any other updates on coming up things or things that happened since we met last before we move on to public comment? Okay, Katie, I think we're ready for public comment.
I know Katie is having some tech difficulties as well, so I'm actually going to introduce first Lou Sininger. If you want to share public comment with us, we're happy to have you. Thanks so much, and go ahead when you're ready. And then after Lou, we'll have Bobby Hall.
Okay, can you hear me?
Yes, we can. Go ahead.
Okay. Well, first of all, Michelle, I missed that Washington State meeting, HCAO for Washington State, but I got some feedback. Everybody was really impressed, so thank you very much. One area I wanted to cover, I mentioned it to the board last Thursday, and that is to as you engage to the community, don't forget the community of unions. Unions represent 270,000 voters in this state. And unions establish the leading standards for wages and benefits, which includes, besides retirement, healthcare. What you need to be aware of is that there are different attitudes and positions within the unions. And I think you need to consider that when you reach out to them. And number one, you have trust fund unions, that is unions, multi-employer unions. You have unions with their own health insurance deal, like the Teamsters. You have UFCW that represents the employees that work in our grocery stores, right? They have their own trust fund, right? So they have trust funds that reach into other states. So you need to be aware that you might get some pushback and concerns about what's going to happen to our trust fund. You have building trades, they have trust funds, and very good trust funds. When those employees are off work because of the seasonal work, they still have health care, even though it's through an insurance company, right? So they tend to be the people. I'm a retired union guy, right? So they tend to be the people that will hang on to what they have because they know what they have. It may not be the best, but they want to hang on to it. And the other thing is, while we are all aware how the employers capture people with health insurance, where if they leave that employment, they'll lose it, right? So that's a weaponization of healthcare. But also, unions will use the same health insurance things that are, that they're bargaining at the table to weaponize health insurance and healthcare. So those are some things I want you all to be aware of. But most of all, the importance of reaching out to unions as a separate group and let them tell you of their concerns and what they want to see out of this. So thank you. You're all doing a great job.
Thanks, Lou. Really appreciate it. Thanks for being here. Bobby Hall, are you able to unmute? Let's see.
All right, I'm unmuted now.
Yep.
Oh, good. I just wanted to mention something that I know people don't like in the current system, and that is that there are so many different levels of pay. And there's the Medicare, which is very low pay, and many people who provide care will not take more than a small percentage from them. And then there's Medicare, which gets more money, but not enough. We have a place in Corvallis that isn't accepting plain Medicare, won't accept anybody just on Medicare anymore, unless they pay it themselves first and then are reimbursed by the government. And then there are people who have different kinds of insurance, so many different kinds of insurance. It must make it very difficult for all the people who are providing care to know, which one does this and which one does that and so on. That's why they have such a large percentage of their shop who are working just to figure all that out. But I think in our system that we're working for, everybody will get the same care. And it might be more in one part of the state than another. I know that's a possibility, but that is something that will work in that part of the state. And that would just solve so many problems. I think many people would like that, and they would like to know about it. Yeah, I enjoyed your program this morning, and I enjoyed it last week too. So thank you very much for that.
Thanks so much for
And
joining.
incidentally, I was the person who passed along something. It was something that came up in a Pennsylvania talk. One of our people in Healthcare for All Oregon, or else it was Mid-Valley Healthcare Advocates, talked to people in that state, and they found that they liked that conversation. Who knows whether some people here would or not? I don't know, but I passed it along. Thank you.
Thanks, Bobby. And clearly we listen and value your input, because I think that's what Craig was referring to, was your public comment from last month. So appreciate you being here, and thanks for sharing your public comment with us. And Craig,
Thank you.
Pennsylvania, just to close that loop.
Yeah.
Yeah, great. Appreciate it. All right, well, that brings us to the end of our agenda. Really appreciate all of you, your comments, your engagement, the work that you're doing, that you're sharing with us, and your questions when we have these speakers. I think you are right in that one of our next tasks is going to be working with Patty Wentz, who's going to be developing the strategic frame and strategic talking points for this work for the board. And we're going to want all of your input on that. So that's why I'm really excited that we've been able to spend a couple of months with some really smart experts. Sorry, my cat's knocking things over on my desk. Preparing us all for that work. And I know that this next piece is going to be a lot easier now that we've had several months of discussing, what works, what doesn't work. So next month, we are going to have a pause. So our committee will not meet. The April committee meeting is canceled, and the April Universal Health Plan Governance Board meeting is canceled. And so there's no meetings next month. It's a great time to maybe sit with your notes from these last few months of meetings and presenters, put together your thoughts, because when we come back in May, we're going to have Patty Wentz back on board with us. We're going to have Diana Bianco from Artemis Consulting coming back on board, and we're going to be starting the work of finalizing some communications decisions and starting to frame up the questions that we're going to use to engage with the targeted list of groups that Senate Bill 1089 charges us with engaging. So the reason we're taking a break is because the Universal Health Plan Governance Board is having a bunch of staff changes. So please, I hope that you can all join Amy and I in thanking Katie, the fabulous Katie, also the fabulous Jenny. They're going on to new and exciting opportunities, and we would not be here without both of them. So thank you, Katie, and thank you, Jenny. And then also the board has just hired a new executive director. So all of the board's staff is turning over, and we're going to give that staff team a little bit of time to get up to speed in the month of April. And then in May, the board is going to go into strategic planning, and we are going to go into prep for that public engagement in the summer. So Amy, did you have something to add?
No, I was looking for a heart for Katie, and then I accidentally raised my hand. So
Yeah.
yes, I also just want to
too.
express thanks for Katie and Jenny and how supportive they've been to all of our committees and the board. Craig, did you want to say something?
Just briefly, this is kind of what we're all up against. I always remember this plaque or a magnet I saw, and it said, "Change is good as long as I don't have to do anything different." It's not real funny, but I kind of sometimes when I'm arguing with people that, it's kind of anyway, it just kind of applies to our group, what we're up against. Thank you.
Definitely applies. Thanks, Craig.
Yes, it's a timely quote. Thanks. Yes, and so change in this case with staff, it's good for them. I don't blame other organizations from talking to our fabulous and talented staff and asking them to come work for them, but definitely we'll miss them and wish them the best in their next role. And so no meeting next month. It's on the website as canceled. And we will look forward to plugging in with all of you in May when we start to apply everything that we've been discussing, learning about as we prepare for an active summer of engagement. So thank you all so much. Really appreciate working with each of you. Take good care, and we will see you in May. And if you have questions or comments between now and then, just feel free to reach out via email. So, all right. Take good care. Have a wonderful rest of March and a good April, and we'll see you in May. Bye, everyone.
Thank you.
Thank you.
Thank you.